Hello everyone, we'll be looking at the monogenic and polygenic concepts in chronic kidney disease, basically to understand the genetic architecture of kidney disease through family studies, monogenic disorders, and polygenic risk scores. Family studies estimate kidney function heritability at 35 to 69%. This captures the complex genetic architecture shared with environmental factors. Genome-wide association studies estimate SNP-based heritability between 7 to 20.3%, identifying hundreds of genetic variants. Monogenic disorders account for 10% of adult and 50% of pediatric kidney diseases with significant diagnostic implications. Family history reveals both genetic and environmental contributions to chronic kidney disease risk. First-degree family members of those with kidney failure face 3.74 increased risk. The Lifelines cohort study found threefold risk across 3 generations. Affected spouses show 1.6-fold risk, suggesting shared environmental factors. So kidney disease clearly clusters in families. High diagnostic yield through genetic testing reveals monogenic causes in early onset kidney disease. Patients with unexplained kidney disease before age 30 have genetic causes identified in 65% of the cases. 7 key genes, that is COL4A3, COL4A4, COL4A5, HNF1B, PKD1, PKD2, and PKHD1 explain most genetic diagnosis, that is 66% precisely. Only half of genetic kidney disease patients have a positive family history. The genetic testing ensures correct diagnosis and avoids unnecessary therapies or interventions. It has a prognostic value. It changes prognosis, understanding, and guides screening for associated conditions. Assisted reproductive decisions and guides living-related donor evaluation in transplantation. Early integration of genetic testing reduces diagnostic costs by 20% when implemented systematically. Environmental risk factors also modify genetic susceptibility, such as socioeconomic status, occupational exposure, cigarette smoking, infections, geographic clustering suggesting gene-environment interaction, agricultural exposure in endemic CKD regions. One great example is from Sri Lanka. The SLC13A3 gene in Sri Lanka CKD carries 50% increased risk, likely interacting with unknown environmental triggers, probably pesticides. APOL1 risk alleles demonstrate complex interactions between genetics, ancestry, and environmental triggers. Initially, G1 and G2 alleles prevalent in sub-Saharan African descent protected against trypanosomes. Following that, it was discovered that 2 risk alleles increased HIV-associated nephropathy risk by 89% compared to controls. Early disclosure of APOL1 improves blood pressure control and proteinuria screening in high-risk groups. Finally, the consensus recommends testing APOL1 in potential living kidney donors of African descent. Twin studies are a natural model to assess genetic and environmental determinants of health through studying monozygotic, that is 100% shared genetic material, and dizygotic, 50% shared genetic material, twins with exposure to the same environmental factors. Twin studies have estimated heritability of kidney function ranging from 18 to 76%, which diminishes with age, suggesting environmental determinants are more important in older age with an underlying genetic component. A study of 662 diabetic participants from 310 families found heritability in EGFR of 75%, albuminuria 46%, and it also demonstrated strong familial clustering patterns. Large-scale genome-wide association studies identify genetic variants associated with kidney function phenotypes across diverse populations. A UK biobank study assessed 35 traits in approximately 3 lakh individuals and estimated heritability. The proportion of the phenotype explained by genetic factors at 20% for EGFR but only 3% for albuminuria. Interestingly, a targeted GWAS in diabetic patients identified a locus in GABRR1 associated with albuminuria in diabetic patients, which was only identified in European populations and not replicated in the Asian population. The heritability gap between family and GWAS studies is exemplified in CKD, where the estimation of the proportion of kidney function explained by genetic factors is much higher in twin and familial studies than in the GWAS studies. Polygenic risk score aggregates signals from multiple genetic loci into a single score, measuring genetic risk based on the common variants. It is calculated by summing estimated genetic risk for multiple independent single nucleotide polymorphisms. It shows a strong correlation with kidney function at population level. However, it cannot predict individual level changes, and environmental factors remain crucial, and it cannot incorporate environmental influences on the genetics. A multi-ancestry polygenic risk score was developed across several populations and found that CKD status was associated with polygenic risk scores in European, Asian, Latinx, and African population. African ancestry populations had higher average polygenic risk scores compared to other ancestries, and incorporation of APOL1 risk allele status in this group further increased the genetic risk for CKD. Polygenic risk score derived from GWAS populations such as UK Biobank requires validation in independent population before transitioning to clinical utility. Several polygenic risk scores have been validated for kidney phenotypes, predominantly from European ancestry. A polygenic risk score for EGFR validated in the ARIC study with mean age of 54 years. Another validation study in the interval cohort of 50,000 participants with median age of 44 years. The youngest population studied an adolescent population in the Netherlands aged 11 to 22 years. The oldest validation cohort was the ASPRI cohort with people aged over 70 years old, which found a clinically meaningful difference between those with high and low polygenic risk scores. Those with highest risk polygenic risk scores had the lowest mean EGFR, whereas the lowest risk score had a mean EGFR of greater than the previous group. Nine genetic variants were found to associate with a decline in EGFR, with high heritability estimates of EGFR decline in those with diabetes and CKD, which was greater when compared to average risk populations with only 0.51% of decline attributed to polygenic risk scores. A polygenic risk score of EGFR studied in the German chronic kidney disease study found this polygenic risk score was associated with kidney failure, but also myocardial infarction and mortality, suggesting polygenic risk scores capture multiple genetic pathways that can be involved in other diseases. Taken together, these studies show that polygenic factors explain a proportion of the variability in kidney function across the lifespan and are a potential clinical tool to help stratify and screen high-risk patients and target groups at risk of decline. Polygenic risk scores have also been utilized in conjunction with proteomic data to identify potential genes and proteins involved in disease pathogenesis. These studies identified proteins positively associated with EGFR, such as clotho, carbonic anhydrase related protein, and so on. Strongest negative association with EGFR was found with cystatin C, collagen A, and desmocolin. UMOD and 10M3 were identified to be important for patients with diabetes and CKD. UMOD encodes stam-Hosfeld protein and is frequently identified in GWAS for kidney traits. The postulated mechanism is through variant activation of the sodium cotransport, promoting development of hypertension, different to the mechanism in ADTKD UMOD. The function of TENM3 in the kidney is still unknown. Identification of these genes offers possible gene targets for future research in CKD. IgA nephropathy is the most common glomerulonephritis worldwide with variable clinical phenotype and course. Family history is positive in 11.6% of patients and is associated with increased risk of end-stage kidney disease, suggesting the genetic component may be associated with worse prognosis. A polygenic risk score for IgA nephropathy was developed in patients with biopsy-proven IgA with 15 SNPs associated with IgA disease. 20 SNPs associated with IgA in GWAS were studied in Chinese IgA patients, and a score to predict progression to kidney failure was generated, which, when added to a clinical risk model, improved the discrimination of the case. Hypertension affects millions of people worldwide and is an important risk factor for CKD with strong environmental and genetic factors and having both monogenic and polygenic causes. Monogenic causes of hypertension are rare but clinically significant, such as Liddle syndrome with an autosomal dominant gain of function in the amiloride-sensitive chloride channel, with the prevalence of 1.5% in young patients with unexplained early onset hypertension. Family studies show that hypertension clusters in families, and population studies estimate heritability at 17 to 52% depending on the population studied. GWAS identified 900 loci associated with hypertension, although they explain only 2% of variance in blood pressure, with each individual locus explaining an extremely small degree of difference in blood pressure. A polygenic risk score for hypertension was generated from large multi-ethnic cohorts, which showed higher average polygenic risk score in participants of African ancestry compared to European ancestry, and found high polygenic risk scores were associated with hypertension with an odds ratio of 2 for African and odds ratio of 1.4 for European ancestry. This polygenic risk score was also associated with hypertension, coronary artery disease, diabetes, chronic kidney disease, obesity, and ischemic stroke. Despite the strong polygenic risk associated with hypertension, lifestyle factors are likely to be more important. A study of 277,000 individuals from the UK Biobank assessed lifestyle factors including diet, smoking, alcohol consumption, sedentary behavior, BMI, urinary sodium excretion, and found that those with high genetic risk and unhealthy lifestyle had higher systolic blood pressure of 146 and 142 millimeters of mercury with an unfavorable lifestyle, whereas those with low genetic risk and unfavorable lifestyle had a systolic blood pressure of 140 millimeters of mercury, suggesting that low polygenic risk cannot mitigate the influence of lifestyle factors. Polygenic factors are being applied in many novel aspects of medicines, including in disease management approaches. A recent study in patient aged 31 years undergoing chemotherapy found that utilizing a polygenic risk score for EGFR was an independent predictor of cisplatin levels, suggesting it may be another modality to consider kidney function across lifespan. Solute clearance in PD is associated with 5 key SNPs from GWAS and may offer insight into assessment of peritoneal dialysis suitability. Pharmacogenomics to identify gene-drug interaction is another potential application, and early feasibility studies show promising clinical utility in CKD management, such as genetic variation in CYP2C9 association with impaired metabolism of losartan and uncontrolled hypertension. Living-related kidney donation is a unique aspect of kidney health and is a potential area for preemptive genetic testing. Cascade testing of potential living-related donors for a family member with kidney failure has a clear benefit in assessing risk of kidney disease in live donors. Assessing polygenic risk in potential living donors is less clear. However, recommendations suggest considering screening potential living donors of African descent for APOL1 risk alleles. The results of APOL1 long-term kidney transplantation outcomes network Apollo will better inform potential donors on possible longitudinal risk. Currently, the role of polygenic risk scores in this area is yet to be defined. Kidney function is determined by monogenic and polygenic factors with important interacting environmental elements. Polygenic risk scores are able to stratify high and low risk groups for kidney disease at a population level, but are not deterministic for individual kidney function, where environmental and lifestyle factors are potentially more relevant. Polygenic risk scores at a population level are useful to assess risk, but their role in guiding individual practice is less clear and not ready for integration into individual patient care. Potential applications include guiding prognosis in targeted disease states such as IgA nephropathy. Of course, an exciting application is the identification of new therapeutic targets in common pathways. The future of genomics in nephrology is personalized medicine, where integration of genetic data into clinical practice for individualized treatment approaches and risk stratification, pharmacogenomics looking at gene-drug interaction, population-level polygenic risk score to identify shared biological mechanisms as potential therapeutic targets in kidney disease. Currently, monogenic testing is well established with 50 to 66% diagnostic yield, polygenic risk score validated in large populations across ancestries. Gene-environment interactions are increasingly understood. Some remaining challenges: individual level prediction accuracy needs to be improved. Integration of genetic results into clinical workflows require refinement. Education is needed for clinicians and patients regarding genetic kidney diseases. Next steps are to develop disease-specific polygenic risk score for better prognostication, combine genetic and clinical risk scores, identify novel therapeutic targets from GWAS findings. Kidney function is determined by complex interplay of monogenic and polygenic factors with crucial environmental determinants. Family studies show 35 to 69% heritability. GWAS estimates 7 to 20% SNP-based heritability, revealing complex genetic contributions. Monogenic testing achieves high diagnostic yield. Polygenic risk score shows promise for risk stratification in specific diseases like IgA nephropathy and membranous nephropathy. Exciting future applications include identifying therapeutic targets, guiding personalized medicines, and integrating pharmacogenomics into routine CKD care. Thank you.